I'm presenting a case of a 50-year-old female by name Gayatri, who is a Hindu by religion, studied till 7th standard. She has occupation of tailor. She is a right-handed individual, hailing from Arsikere, Hassan. Informant was patient and her husband. Come to the chief complaints. Weakness in both the lower limbs since 2 months. Loss of sensations below the level of umbilicus and in both the lower limbs since 1 month. Bowel and bladder disturbance since 1 month. Come to history of presenting illness. The patient was apparently all right 2 months back when she developed weakness in both the lower limbs, so an insidious onset. Initially, patient had difficulty in getting up from squatting position and also difficulty in walking around inside home. She used to walk with the support of the wall inside the home. After a span of 2 weeks, the patient weakness gradually progressed such that she required help of one of the family members to move around the house, inside the house. At this point of time, there was no sensory symptoms, bowel or bladder disturbances. Over the next 2 weeks, patient had difficulty in getting up from the bed or moving sideways in the bed. She required help of 2 family members at this point to do her daily routine activities. And there was no history of weakness of upper limbs or no history of fluctuation of weakness at this time. She also developed feeling of numbness in both the lower limbs, initially involving till ankle, then gradually progressed to involve entire limb over next 2 to 3 days, which was followed by loss of sensation in both the lower limb, where she was not able to appreciate her clothes and also not able to feel hot and cold water. Patient also gives history of bowel and bladder disturbance since 1 month, where she was not able to feel the fullness of bladder. Because of it, there was distension of abdomen below the umbilicus, for which the patient attendants used to carry her to the bathroom, during which there was rippling of urine, and also there was history of difficulty in voluntary initiation of menstruation. Patient also history of bowel incontinence, involuntary passage of stools in the bed. There is history of back pain occasionally, but there is no history or any injury to the back. No history of dog bite or any recent vaccination. No history of recent drug intake intrathecally or any spike surgery. No history of radiation to the back. No history of evening rise of temperature, cough, expectoration, weight loss, bone pain in the back or any corpse contact. No history of chronic radicular back pain. No history suggestive of Lyme-Disease phenomena or Barber Strait strain. No history of arthralgia, photosensitivity, rash. No history of any high-risk behavior. No history of fever with chills and rigor, cloudy urine or hematuria. No history of unilateral or bilateral swelling of the lower limbs. No history of breathlessness. No history of altered sensorium, loss of consciousness or convulsions. No history suggestive of any cranial nerve involvement.
Okay.
Shall I continue?
We'll start discussing. Okay. Symptoms.
Oh.
You told that this person's illness started as difficulty in walking, getting up from sitting posture, no? You told right-handed, no? So how did you come to the conclusion, right-handed?
Yes, ma'am.
How, ma'am? How did you come to the conclusion? You have told she's right.
I asked her routine activities, ma'am. She used to thread the nails with her right hand during tailoring. She used to hold objects predominantly in right hand in the combing of hair.
So normally, what just to ask only, she is right-handed. I agree. What is the relevance of handedness in neurology? What situations, ma'am? Supposing you are planning a tumor surgery or epilepsy surgery, no? If it is on the dominant side, you can prognosticate the outcome, maybe language will be affected. Or if the person is ambidextrous, outcome may be better, opposite side will take over. And most important, most of the any degenerative disease, all the neuropsychological tests available are done only for right-handed people. So we don't have the normative data of neuropsychological evaluation in left-handers. So want to know the dominance and to prognosticate outcome during surgery for epilepsy, surgery for tumors, whether the patient is going to lose the language. Second, if it is ambidextrous, recovery will be there better. Then cognitive disorders, patients, neuropsychological disorder. It is, as you said, routine activities you ask. Otherwise, there are several methods. One, I am sure, handedness goes with tiredness. We are generally, it is not 100%. Right hand, right eye, left ear, left foot. That is the way it is dominant. It is more obvious in males than females. So you can tell the patient to fix at a illumina tube light or bulb. With the illuminoscope, I think you may be doing it also in our times to check translucency. We used to roll a X-ray film and look through it with the light projector from the opposite side. So that can be used as a thing to focus. So give it to the patient, tell him to focus on an object, which hand he is using. So handedness goes with tiredness. That is one important point. Yeah. Otherwise, you can, apart from the routine questions you have, like this you put, no? Quickly, without telling, then the dominant thumb will be down. Put like this, dominant thumb will be down. Then if you put a back, tell the patient to put the hand back, the dominant one will be above. Those are some methods. Then we have got routine EEG is available for all of us. If you do the EEG, left hemisphere is an active hemisphere. We are either talking or listening or reading, doing some language related activity. Whereas right hemisphere, when you are singing or when you are emotional, you are doing some creative, then only it is active. So normally right hemisphere relaxes, left one is functioning. So you do the EEG, alpha is a rhythm of relaxation. So you formed a better formed alpha rhythm on which side? That is a relaxed side, non-dominant side. So that is a simple test available everywhere. Third, you can do the olden days, not now, it is not done, Amytal test. Intracarotid Amytal, tell the patient to stretch both hands and keep counting. And on which side, when you are injecting the counting stuff, that is a dominant side. Then you have got a FMAS. But at the bedside, even without all these things are not needed. You have got a Edinburgh's handedness inventory. You have got two types of inventory. One is a small number, it is 10 points. Another one is an extended inventory, which contains most parameters, especially if you are using to substitute it during tumor surgery or something like that. And in a place where you don't have FMRI and other facilities, then you can do the extended handedness, Edinburgh's handedness inventory. So that is the method by which you decide handedness. Next, you told that this person developed a difficulty in walking. So what you told that she has difficulty in getting up from the sitting posture also. And both lower limbs were weak, but initially sensations was normal. That's what you told, I think, no? Initially, no? Is that the first thing was motor, no? You go next. I think you told them weakness. Weakness came first. Sensation came later. Am I right?
Yes. Initially,
which one, ma? First thing was weakness or sensory? Weakness, no? Numbness, both
weakness,
first weakness. So that's what I remember. So weakness can be, so it is apparently started with motor involvement. So then with gait difficulty, you want to know which one, ma? Motor, no? Am I right? That's what you have told. That's what you have written. Numbness came later. Difficulty in. So it is a motor also. He started with the motor pathways. So you want to know whether the motor pathway problem is LMN or UMN. That is what we have to decide. So first thing we started is motor pathway. LMN can be muscles, myoneural junctions, motor roots, no? And motor nerves. So that is LMN. UMN will be the motor tracts in the spinal cord or the motor pathways in the brain. Cerebral hemisphere, that is in the interhemispheric region. So these are the three locations where you will put a motor weakness. So see what is, if it is LMN, difficulty in walking is there and difficulty in getting up from squatting posture. But what was making the patient difficult in getting up from squatting, all those things, whether it was if the patient is able to tell, you should tell. If the patient is unable to tell, you should say, I asked, but my patient is unable to tell. So is the patient unable to get up due to stiffness? Or the limb was flail? Was the limb hanging loose? Was the patient buckling? Was it dangling? No, was it stiff? So that is important. If the limb was stiff, you know, it is upper motor neuron. Heaviness. Heaviness indicates weakness only. So heaviness means I am sure you know that true heaviness does not happen in ordinary situations. True heaviness happens when you have got a limb pharynx, severe edema, arteriovenous fistulas, filariasis, no? Those conditions, the weight of the limb really becomes more. It becomes more heavy. Otherwise, whenever the patient says heavy, what he means is he is putting more effort to do work. So what is the work that we do with the limb? Moving forward. So when you move forward effortlessly, you feel it is okay. When you move forward effortfully, patient will say heavy. It is not really heavy. It is more effort is needed to move forward. So if heaviness means only weakness, heaviness means weakness, then you have to differentiate between human and element by history as well as by examination. By history, as I told, if the patient says that high stepping, flail limb, and it was buckling, or there was a specific semiology of getting up when the patient gets hip up, sign like that, or toe injury like that, if they are getting history, it may be element. Focused difficulty like proximal muscle weakness, then they will have the hip up sign, they climb on their limbs, tripod and all those things. Or if the limb is high stepping, flail, dangling, or slapping, buckling, all those things will say it is element. But supposing the patient says, I could not get up because of stiffness. So that we will ask in the history only, because as you all know that this may not be relevant in this particular case, but getting that habit is very important so that in a difficult case also you will not miss. Systematically going through like that. So if the patient says stiff, then it is going to, and the patient was dragging rather than high stepping, flail, hip up, buckling. Instead, patient was dragging. So if the patient says my limb was stiff and I was dragging, and maybe sometimes they circumvent. Supposing there is an upper motor neuron induced dorsiflexor weakness, they rather circumvent. Whereas LMN, they will do high stepping or slapping. LMN patients do high stepping or slapping, whereas EMN patients do circumduction. So that point you can ask. Then when you examine, of course, you are a postgraduate, still undergraduate students might be there. So how to differentiate LMN from EMN motor weakness? Examination, you will find there is deep reflexes are exaggerated, superficial reflexes are absent, upgoing plantar response. There is no much wasting or fasciculations in the early course of the disease. And, whereas in LMN, both superficial and deep reflexes are lost, and plantar will be flexor. And you can, if the person is coming to you sometime later, wasting and weakness sets in early. So that is motor weakness. So in this patient's history, we have not got all those points. So we don't know whether it is the LMN or EMN, only it is motor. So motor pathway, what is special, whether it is in the LMN level or in the EMN level. Two aspects are special for motor tracts. Then I always tell, do not forget cerebral paraplegia. I always discuss it because we might miss it easily. Cerebral paraplegia is paraplegia due to Fox region tumors or any other lesion in the Fox region, where patient will have cortical sensory loss. They can have Jacksonian seizures, and their weakness is usually having a sensory loss in a disproportionate. Weakness is below hip means sensory is below knee or ankle because of the nature of the homunculus. And when you examine, the sensory will be cortical sensation. So presence of seizures, sensory or motor, cortical sensations below knee, and bladder of frontal uninhibited bladder, and of course upper motor neuron features. That is a cerebral paraplegia. We have discussed last time also. So now what we got at that point, the heralding thing happened in the motor pathway. So what is special? Motor, element or human? They are the most myelinated pathways. So motor fibers and posterior column fibers are the most myelinated fibers, both in the element and human. So if a disease is affecting only the motor fibers, either it is element or human, is it a myelin related disorder? That is one question. But supposing this person says that she had this symptom for 10 years, not 1 month. Then you have got tractopathies, which involve the motor tracts, like hereditary spastic paraplegia, adrenoleukodystrophy. No? Then you have got this Kesari doll poisoning. No? So these are spastic tract diseases. They involve only the motor tracts. They are called tractopathies. If the duration had been long, you will consider tractopathies which involve these tracts. Or if the duration is short, you will think of myelin, which is the common thing either in the human or element for the motor fibers. They are the most myelinated. So is my patient getting a myelin-based disorder in the element or human? Is what you will ask in this patient because it is only 1 month. And after that, patient developed sensory symptoms. In the motor thing deteriorated and she needed, that is called as Ashwath grading. So you walk independently, then walk with 1% support, 2% support, bed bound. So that is a severity of the motor weakness increase. The grading score is called Ashwath score. Okay. So then the second is the sensory symptom. And next one, go to the second one. Well, sensory symptom was numbness in both lower limbs. But did the patient feel any burning sensation, pricking pain, cold, warmth, no? Any sensation was there or not? That's the next question. Because sensory, you have got proprioceptive fibers and you have got pain and temperature fibers. So we want to know which one got involved. First, next in that order. If it is a numbness with a tingling sensation, then it might point to again the next most myelinated sensory tract, that's the proprioceptive fibers. Whereas pain and temperature fibers are the least myelinated. So when you are thinking, is it a myelin-based disorder, you are expecting the proprioceptive fiber to get involved second. So apparently it looks like that because patient did not feel any burning sensation. Patient did not feel any pricking pain. Patient did not feel any feeling of cold, but it was a numbness. So probably it is a proprioceptive fiber that got involved. That's also myelin. So probably it is a myelin-related disorder. We are strengthening our suspicion. And then she lost all sensation. So it started with the myelinated fibers. Then it went on to involve all sensation. Completion of pathology, everything will be involved. So now at this point, we want to know, still we have not elaborated the points in favor of element or human. So we will see what are all the points in favoring element or human in this case. So element means it is usually sensations are length dependent. And rarely you have got non-length dependent, mononeuritis multiplex or radiculoneuropathy, non-length dependent. Usual sensations are length dependent, so it will be distal more than proximal. But you said that these patients' sensations went up to the umbilicus. So can element disease go up to the umbilicus? It can. Supposing it's an intercostal nerve and the lumbar nerves are getting involved. Supposing intercostal nerves and lumbar nerves are getting involved, the sensation can go to the trunk. But it will be anterior trunk. Because the distal part for the intercostal nerves and the lumbar nerves is para-umbilical, parasternal. So it is like a length-dependent foot or length-dependent glove and stocking. The glove and stocking equivalent in the intercostal and the lumbar nerves is parasternal and para-umbilical. So it will not be around. It will not be around. So if the sensory impairment is around, it goes to the human. If the sensory impairment is parasternal or para-umbilicus, it goes to the element. So this person Probably it was around, I think so. In that case, it goes to the human. So we are using that data to say that our patient's problem is human. First, we thought it is a myelin-based disorder, which went on to complete the problem. Second, probably the sensory is qualifying for a tract involvement rather than a nerve involvement. Then you have got the bladder. You can use that bladder also. So patient, did she appreciate? So bladder description is, of course, she is having some dribbling. So we will ask so many questions: pre-voiding phase, voiding phase, and post-voiding phase. Pre-voiding phase, according to you, she did not appreciate the fullness. Instead, she found a distension. Is that what happened? No. So patient felt distension,
yes,
not appreciating. So that can happen in automatic bladder and autonomous bladder. Both bladders, fullness and pain may not be appreciated. Second, what is the difference between automatic and autonomous bladder? Autonomous bladder will be a completely disconnected bladder, only the sacral center is there. So what happens? You see the disease is in cardiac canal, sacral center is destroyed. So actually the lesion is in the sacral center and it is destroyed. So we have only what is retained is the bladder wall receptors. Normally we are having beta receptors in the body, alpha receptors in the sphincter, which keeps it closed. So the urine will come and bladder will keep on expanding, and the capacity of the internal sphincters fails at 1.5 to 2 liters. So at that point, the weight of the urine will open the internal sphincter and the patient will start dribbling. So autonomous bladder is a large bladder, no appreciation of fullness or pain. There is no spontaneous emptying and there is continuous dribbling once the dribbling starts. Whatever amount of urine which accumulates beyond that 1.5 to 2 ml capacity starts dribbling. You know the urine is secreted at the rate of 0.3 ml per minute. So every 0.3 ml secreted beyond that 1.5 to 2 liter will leak out. That is autonomous bladder. Whereas automatic bladder, sacral center is there. Whereas higher centers are disconnected. So what happens? The bladder wall capacity is about 150 to 250 ml. That much urine will collect. And then the bladder will go and tell the sacral center. The sacral center can sustain little more urine. And sacral center will carry that impulse through the ascending pathways to the higher centers in the pons, the Barrington center, and the cortical centers, and ask for the social cognition. So is it possible to empty now? So if it is okay, then from the cortical centers, the emptying reflexes will be initiated and micturition is started. So this is disconnected. So what happens? Patient's bladder goes beyond the bladder wall capacity. It goes to the capacity of the sacral center, about 300 to 400 ml. At that time, it tries to communicate with the cortex. There is no link. So what happens? The bladder starts emptying automatically. So pre-voiding phase, depending on completeness of the lesion, sensation may be felt or may not be felt. And once the urine comes to the capacity beyond the sacral center's capacity, it will spontaneously start emptying. So patient will start emptying automatically. That is why it is automatic. Patient starts emptying automatically and it starts emptying and it will empty incompletely because only that small amount of urine that is beyond the capacity of the bladder wall receptors will empty. So about 300 ml of urine will be emptied. Patient has no control over either initiation of micturition or emptying of micturition. He doesn't have any control over initiation or emptying. So once the urine continues to empty and at the end of the time at which the sacral center is no more stimulated, bladder will stop. But there is a post-voiding residual urine because there is a detrusor external sphincter dyssynergia. In all neurogenic bladders, there is a dyssynergia between the body and the sphincter. So because of that dyssynergia, the bladder will have residual urine. So sensation may or may not be preserved. then automatic emptying starts, and emptying stops also automatically. Patient cannot stop micturition in the midstream, and post-voiding dribbling may be there because of residual urine. But pre-voiding dribbling is not common in human blood. So if it is true that patient had a painless distension and dribbling, apparently it can qualify from this history only for an autonomous bladder. Continuously dribbling, large bladder, painless bladder. Large continuously dribbling painless bladder is an autonomous bladder. Whether it is really that, we have to ask more questions, or whether the patient just started filling and the bladder symptoms came and patient taken to some hospital. They have catheterized, means you will not get a time to get the real nature of what happened to the bladder. So if it was a continuously dribbling bladder, it is autonomous. She was carried to the toilet, but was she able to empty her bladder? Or was it only dribbling?
It used to get dribble only.
Only continuously dribbling, not emptying at all.
Yes.
So that looks like an LMN bladder, apparently, if that history is correct. Looks like an autonomous bladder. What is a shock bladder? In this patient, I don't think it is a shock bladder. Sudden transection of the cord will produce a shock, spinal shock. What will be the nature of a bladder in shock in the acute phase and then subacute phase? Mostly we don't see them in the acute phase. Most of us see the patients in the subacute phase only. In the acute phase, patient is atonic, areflexic with the atonic bladder. So the bladder, neither the body of the bladder will store nor the sphincter will store. Because of that, patient will have a small dribbling bladder. Unlike an autonomous bladder, which is a large dribbling bladder, shock bladder in the immediate phase is a small dribbling bladder. Then in the order of recovery from shock, first thing to recover is the sphincter. So it will go to retention. So immediate bladder is neither it stores nor it keeps the sphincter closed. So it's a small dribbling bladder. Shock bladder starts as a small dribbling bladder. Then the sphincters recover earlier. Because of that, then it goes to retention. Usually at the retention phase only we see them. So when we examine, you have to do the bulbous cavernous reflex to know whether it is LMN or EMN. And if the person is already catheterized, people say that you can just pull up the catheter and palpate the perineal muscles with a gloved hand. If it is an LMN bladder, you will find that the perineal muscles are not contracting. And if the perineal muscles are contracting, it is a EMN bladder. Catheterized patient bladder characteristics cannot be analyzed. Once the person is catheterized very early, you cannot analyze that. Then the way to differentiate is pulling at the catheter. That is the way to elicit the bulbocavernous reflex in such patient. What is the relevance? LMN bladder is very bad, whereas EMN bladder can be trained to some extent. It's better than an LMN bladder. So in this patient, we want little more information. If it was continuously dribbling bladder, either it could be a shock bladder or an autonomous bladder. In this patient, as it came subacutely, very unlikely to be a shock bladder. Shock bladder comes hyperacutely. So whether the person had an LMN bladder, we don't know. So EMN plus LMN involvement, myeloradiculopathies is a possibility. We'll keep it in our mind. A patient also had bowel incontinence. No, that's okay. It is like the bladder only we have to analyze. Next, what happened? Next one. So it is a definite level is there. Is it subacute? Started with a myelinated tracts and went on to a pan cord syndrome, apparently. And spinal cord disorders, we categorize them into, first when you have taken history, anterior cord, posterior cord, pan cord, hemicord and central cord, for trying to fix in our mind the etiology. Supposing you have got an anterior cord, you will think of an anterior spinal artery syndrome. You have got a posterior cord, you might think of a posterior spinal artery syndrome, or subacute combined degeneration of the cord, or Bellman's posterior column ataxias, which are less common syndromes. And hemicord, you might think of a bullet shot injury trauma. Or if you have a central cord syndrome, you are going to think of a whiplash. If you have pan cord syndrome, you are going to think of a transverse myelitis. or if you have an isolated tract involvement, you are going to think of tractopathies. So like that. So at this point of time, your patient has got a Pankot syndrome. Everything is involved: autonomic system, sensory system, and the motor system. Is it acute, subacute, or chronic? Apparently, it is subacute. One by one, things are getting recruited. It did not happen in a hyperacute fashion. It happened in a one by one fashion. So third point, so it's a subacute Pankot syndrome, where the initial heralding thing was motor pathway. Next is probably proprioceptive. The common thing for them is myelin. So that is one. Second is, you have got pressure sensitivity or ischemia sensitivity or toxic sensitivity. So pressure sensitive tracts are posterior column and the corticospinal. So is it a compression? Some kind of an intradural granuloma or mass lesion, which is compressing, suddenly expanding and becoming symptomatic. That's a second possibility. Myelinated tracts are not only vulnerable for myelin-related problem, they are also vulnerable for compression. So second possibility, is it a compressive? Just to remember, think of your cervical spondylosis patient, senior citizens coming with cervical myelopathy. You see, they will have some stiff gait. They may have some root pains, and they never complain about sensory pain and temperature symptoms. When you examine, you might find that the vibration is impaired apart from the corticospinal tract. So compression also prefers the corticospinal tract and the posterior column. So first, because it is subacute, for 1 month it was weakness, then the sensory, and then the bladder. So it is going in a subacute fashion. So I would also like to consider a compressive lesion at that level. If a patient, so we'll later come to what is compression versus non-compression. So these are the two differential diagnoses. What is the tract which is sensitive to ischemia? It is usually the autonomic fibers and the pain and temperature fibers. Ischemia, vasculitis, like Behçet's syndrome, or you have got the Sjogren's syndrome. They can all involve the spinal cord. Sjogren's, Behçet, when they involve the spinal cord, they generally prefer the autonomic fibers and the small myelinated fibers first, and then go to involve the others. Whereas toxins involve the small myelinated fibers, and generally they spare the autonomic fibers, with some exceptions. Some exceptions are there which involve the autonomic fibers also. So that is the way we are going to see. So is it a compression or a demyelination is the question. Because of the subacute nature, we are putting compression as a differential diagnosis. And involved, started with motor and proprioception. So how to differentiate compression from other non-compressions? One is, compression means, anybody wanting to tell, you can tell. It's a common thing only.
Compressive pathology usually have root pains.
Yes. First tell extradural compression, then tell intradural, then tell intramedullary. Tell ma'am. Extradural disease is what? Usually vertebra. No. So patient can have gibbous. So compression may be extradural compression, intradural compression, or intramedullary compression. Yes. So extramedullary compression, what are all the features? Extramedullary, extradural comes either from the disc or the vertebra. So disc or the vertebral pathology. So you may have a local gibbous, tenderness, paraspinal muscle spasms, and you can get root pains. And usually vertebra and the disc are in the midline, so they are symmetrical disease. So extradural, extramedullary compression, most important point that helps you to differentiate from intradural is the gibbous and the deformity. Gibbous, deformity, paraspinal muscle spasm is seen in extramedullary, extradural. Whereas extramedullary, intradural comes from the nerve roots. They are meningiomas, neurofibromas. They are the intradural conditions. So they are usually eccentric. They do not produce any gibbous. They do not produce any paraspinal muscle spasm. Root pains are more common because they start from the roots only. Whereas in extradural intervertebral phenomena is involved You may have root pains, of course, but root pains are more common in intradural. But root signs are less common. Because there is so much of space for the root to move about. Root pains come on and off, but root signs are less. Whereas extradural, root pains are there and root signs are also there. Then because as I told, it is usually roots, asymmetrical. So paraparesis will progress in an asymmetrical fashion. It will start in one limb and slowly only go to the opposite limb. And both these compressions, bladder is a late symptom. Our patient also got a late bladder. So, but it started symmetrically. So if you are going to done definite upper level. So compressions have definite upper level. So our patient has got a definite upper level. She did not have any root pain. She did not have any root signs. And she had a subacute progressive lesion. Apparently from the history, there is nothing to suggest an intradural or a extradural compression. Intramedullary or syringomyelias or spinal gliomas, ependymomas, such tumors, they are also slow growing tumors, even syringomelia is slow growing. But just for the sake of discussion, if you tell, they get descending suspended dissociated anesthesia. Because syringomelia or the intrinsic tumors, they dissect ventrolaterally. And ventrally, you have got the crossing spinothalamic, laterally, you have got the anterior console. So you get a descending suspended dissociated anesthesia. This may be later followed by element sign in that segment. And late in the course of the disease only, the whole limb becomes weak. Initially, it is a suspended dissociated anesthesia. Second, in that area, you get anterior console features. And then only you get the long tracts. So the long tracts are late. We generally tell bladder is early in intramedullary. You can tell that if your teachers are wanting that, but intramedullary versus intrinsic is there. Intramedullary lesions like syringomelia bladder is very, very late because it is all unilateral. The lesion is unilateral and becomes bilateral very late. Whereas intrinsic lesions like transverse myelitis, bladder is early. So it is not that intramedullary lesions always produce a early bladder, not correct. But whatever is conventionally people teach that intramedullary early bladder. But if you think of the number of syringe patients you would have seen, none of them get an early bladder because it is eccentric. And there will be no gibbous, no deformity. They do not have any root pain, but they will have tract pains. Spinothalamic type of tract pain. Those are the compressions. Non-compressions, you have got acute non-compressive lesions and chronic non-compressive lesions. Chronic non-compressive lesions, upper level will be very vague. No gibbous deformity, paraspinal spasms or root pains. And you may have distant signs like optic atrophy, or you may have peripheral neuropathy. So they are distant signs. So upper level is very vague and distant signs, no gibbous paraspinal muscle spasm, and bladder is not there or very late. That is non-compressive, subacute. Whereas acute non-compressive, they present as Pankot syndromes with bladder, acute transaction with one level involvement. So that is how you differentiate. So apparently it looks like a subacute Pankot syndrome. Still, I do not believe, even though I told compression as a differential diagnosis, because it is very symmetrical and very pan, it still looks like a demyelination, and demyelination can progress up to 8 weeks, even though we generally see them very faster than this. Generally, the progression completes by 8 weeks. So because it progressed one by one, I am putting that another etiology also as a mass lesion. And it started with the pressure sensitive tract. Okay, so at the end of your history, you will tell my patient has got a Pankot syndrome. We started with the myelinator fibers and ended with completion with the small sensory as well as autonomic fibers. There's a definite upper level. There are no distant signs. And apparently, I am not having symptoms of root pains or vertebral pain. So it looks like a subacute Pankot, probably demyelination. Second, still I will keep the differential diagnosis of a mass lesion as it started with the pressure sensitive tracts. That is the history discussion I would like to tell. And would you like to tell anything? Any other differential diagnosis in your mind? You only told that your patient does not have any features suggestive of cranial nerve involvement and no other system involvement. Okay, go on. On examination, what did you find? Any other information is there? No. Any other history is there?
Yes, ma'am.
What specific?
Past history.
Paraplegia.
Patient had no history of similar complaints in the past. She gives history of a lump in her left breast with blood and serous discharge from the nipples, which was operated 11 years back. And she had similar history of lump in the left breast, which was operated 8 months back at a private hospital in Tiptur. And they don't have any records now of the past 2 years. Family history is not significant.
Did she undergo any chemotherapy or radiation or anything like that?
No, ma'am.
No.
They only surgery 2 times now.
Okay.
In general physical examination, middle-aged female, moderately built and nourished, with the urinary catheter in place with due consent. Patient was conscious, cooperative, and well-oriented time, place, and person. Temperature was normal, pulse was normal and regular. BP was 120/76 mmHg, taken in supine position, right brachial artery. JVP was normal. There was no signs of pallor, icterus, cyanosis, clubbing, or edema. There was left supraclavicular lymphadenopathy present, which is hard and fixed on palpation. There are no neurocutaneous markers or stigmata of TB or atherosclerosis. There is a surgical scar present over the left mammary area. And on back examination, there was no kyphoscoliosis or any spinal deformity seen. Skin over the back is normal, no gibbous or no epidural swelling or no spinal tenderness.
Okay. Okay.
Is conscious, cooperative, well-oriented, time, place, and person. Memory is intact and speech is normal. Cranial nerves examination is normal. Coming to motor system, the attitude, patient is lying on the bed comfortable. There is no wasting of the muscle. Measurements are equal on both the sides. On examination of tone, upper limb, the tone is normal. In lower limb, there is a increased tone, hypertonia in the form of spasticity. Power examination, upper limb is normal, 5/5. In lower limb, in all the group of muscle, it is 0/5. And there is truncal muscle weakness also present. In reflexes, superficial reflex, abdominal reflexes are absent. Plantar were extensor bilaterally. Anal reflex were absent. Deep abdominal reflex were absent. And on asking the patient to raise the head in supine position, there is upper deviation of
The anal
umbilicus.
reflex is absent. That gives corroborates with your bladder symptom. So apart from the element, probably there is some apart from the UMN, probably there is an element. Anal sphincter is lax, huh?
Yes.
So okay.
Yes. Deep reflexes in upper limb it is 2+. In lower limb knee it is 3+, ankle 3+, and in left side 3+ with clonus present now, which is ill sustained.
Okay.
Coordination, upper limb coordination is normal, lower limb coordination could not be assessed because of 0/5 power. Sensory system, there is superficial touch, pain, temperature, vibration, and position sense are lost below the level of umbilicus. Cortical sensation not done as a primary modality of sensation lost below umbilicus. There were no abnormal movements and no signs of meningeal irritation present. Other system examination was normal.
Okay, so apparently after examination, in a patient probably who had a recurrent malignancy with the regional lymph nodes, there is a PANCOG plus an element, I think.
Yes, ma'am.
The element is bladder, sacral roots maybe. So bladder and the bowel. So that we will call it as a myeloradiculopathy only. And no gibbous, no paraspinal spasm. So in this patient, I would like to think of a malignant arachnoiditis, malignant deposit with an arachnoiditis, most probably. It can go subacutely compressed. And a malignant arachnoiditis there. What is called it as a drop metastasis. I think you might have heard of drop metastasis, no? Lesions which are higher above they can drop the malignant cells and they can pick up the roots. In other words, it is a root involvement. So you can call it as a arachnoiditis, malignant arachnoiditis. Common arachnoiditis is tuberculosis, fungal lesion, spinal subarachnoid hemorrhage. So they are the causes for arachnoiditis, but malignancy also produces an arachnoiditis. So probably it is an arachnoiditis due to drop metastasis involving the sacral roots, as well as lesion at D10 level producing a myelopathy. That is what it looks like from the history. Most likely it is related to that lesion only. Maybe it is a compression, because compression also, as I told, is started with the motor tracts. Motor tracts, where are they situated? They are situated close to the central canal. They are neither ventral nor dorsal. So an intrinsic tract is symmetrically getting involved. That means it is not by direct involvement, it is by the specific sensitivity. So that is why compressions also involved. Like what I told, all cervical spondylotic myelopathies in senior citizens produce only posterior column and pyramidal. So second possibility is compression. So considering your presentation examination finding and root involvement, I would like to consider myeloradiculopathy, radiculopathy involving the sacral roots, probably by arachnoiditis, palisading infiltrations, they are called, no? Drop metastasis or palisading infiltrations happen. That may be the cause. So shall we see the investigation?
Yes, ma'am.
Very unfortunate, no? So brain, would you like to describe the spine, ma?
Yes, ma'am. Cervical spine is normal. In thoracic spine, there is a compression.
Kyphosis. There is a kyphosis at lower thoracic region with wedge compression fracture, anterior subluxation of probably, I think it is D8, D9 level. How many numbers it is? 1, 2, 3, 4, 5, 6, 7, 8, 9. So it is 9, 10, 11. 10, 11, 12, I think. 10, 11, 12 is vertically compressed wedge and anteriorly subluxated. And you are having multiple lytic regions in many vertebrae. Yes. Spinal cord as such, intrinsic lesion is not there. That we also did not think. So compression versus demyelination, intrinsic is not there because it rules out demyelination also.
Yes.
So it is the second possibility we consider, that is compression. What I want you all to understand, what is these vertebrae called? The white ones in the cervical, they are called ivory vertebrae. You see, this one and this, they are called ivory vertebrae. Ivory vertebrae, acquired ivory vertebrae are metastasis. Sometimes in lymphoma also you get that. Otherwise, marble bone disease, where it will be uniformly ivory. Marble bone disease, you may have that young children, long bones will be involved along with the vertebra, but older people, lymphoma or metastasis, these are called ivory vertebrae. So it is very sad for Gayatri. Anyway, one thing why I discussed like this, I'm sure you might have made the diagnosis instantly, but we go through this discussion so that you will learn that posterior column and corticospinal tracts are pressure sensitive tracts. So special vulnerability for the tracts is there that you see in your own case. Then you get to fix it in your mind because clinical neurology is dying. So without clinical neurology, the tragedy is small. When we take one of our relative to your doctor, you will understand they will investigate with all the tools available and finally treat an incidental pathology and not the real disease. neurology, if you depend on the tools will pick many incidental lesions which may not be causally related to your problem. So that is the biggest tragedy, especially in the private sector. Now I retired 2 years back and now I am in the private. It is very, very sad, you see, because people have forgotten clinical neurology. So it is important. So you yourself, we went through the discussion and I told you process sensitivity tracks or corticospinal posterior column. That's the way this patient evolved. So you are now convinced that symptom is correct.
Yes,
and when you see a case, you will plan it like that. So that is the thing. It's very sad for her. We'll pray for her. So very good, ma. You got a very good history and you presented very well.
I have video viewers side.
Yes, ma'am. Why she did not get any chemotherapy or radiation, we don't know, no?
They did not go for follow-up after surgery.
Okay, good, ma. Only thing, would you like to think of any paraneoplastic conditions? It's very unlikely because definite level is there. The paraneoplastic or do not show a fixed level. They can be cerebellar, peripheral element roots, no? Like that it can happen. Okay.
How to say anatomical localization? Sensory, motor, and reflex level.
So in this patient, you have got a motor level at D10. Sensory level, where did you get? You can get very vague because so many lesions are there. Which one is contributing to? So you can have patchy in this case. Multiple vertebrae are involved. One vertebra might produce a root, another might produce a tract. But in your case, it is very clear now. My element is there at the level of the sphincters. You will say that you are still considering element. Those vertebrae are also affected. Evidence by a dribbling bladder and lax sphincter. Dribbling bladder and the lax sphincter indicates an element involvement of the roots. And it may be a palisading radicular infiltration or an arachnoiditis. We don't know, or it is a sacral vertebra itself, which is producing a effect on the sacral roots. Otherwise, motor level is D10. What about your sensory level? Sensory level also D10, no? So,
yes,
and your reflex level, upper abdominal is present or absent? Upper abdominal also absent. So your reflex level is D6. So if you want to tell, your reflex level is D6 because upper abdominal reflex is absent, whereas upper limb reflexes are normal, apparently. So your reflex level is D6. Motor level is D10, sensory level is D10, element level is sacral roots, like that. And how to approximate the vertebra versus cord, you know that cervical vertebra add 1, upper thoracic add 2, lower thoracic add 3, and the cord stops at L1. So that formula is applied. Okay, good presentation. You had a very good history, but you should continue this exercise throughout your life. Once you get your degree now, you should not forget this. The importance is you will applaud yourself. You are a very good clinician like that. And we should not fall down into the trap, no? Laboratory trap. And you will help many patients restrict their money spent on investigations. So that is, you are all small boys and girls. I am retired and I am in the private sector. I feel it is terrible. In Tamil, there is one Cheethalai Chatana. You know Cheethalai Chatana? He was the king in the Pandya Raja's court. He was a poet. The king made a wrong person as the chief of poetry. So every time mistakes were made in poetry, this person cannot voice because it's the king's court. So he'll hit his head. So Cheethalai means infected head. So the terrible tragedy happening to the patients by big hospitals, you cannot open your mouth at all. Even though it is true that patients are hitting, beating, killing, all those things are happening. But are we right? Because we cannot control the society, we cannot control the patients, but we can control ourselves. We should equip ourselves, we should put effort, because as I always tell, they are giving in our hands their most valuable possession, that is their life. You have to respect that. Then over a period of time, as an individual, you will definitely get respect. You see, when I started my career, I came from Tamil Nadu to Kerala, and it's a more literate state, more demanding state. So we thought they saw a very unimpressive, very low profile Tamil lady. And always I faced difficulty for the first 1 year. When I told I did not understand your problem, then also they thought this lady doesn't know anything. But after 1 year, people started telling that if she doesn't know, she will confess. I was in the government medical college. Then before I went to NIMHANS, State Medical College. So now when I have come back, people come back and searching for me, for the honesty. So at least they know that nobody can know everything in medicine. It's not possible. But people know you don't cheat them. So now I am old, that I am enjoying. You see? So we will be truthful to ourselves. That much only we can do. Slowly, if all of us, the proportion of people who are truthful and committed doctors improve in the society, I think the patient violence will come down. Except in stress situations. Slowly, it may take 1 century to transform this. Because one period of laboratory medicine, too much of money, too much of stress, so they throw it on the doctor. Now it has to go through a phase of revolution so that the old respect is earned back. It will come slowly. That's why I always tell this. And now you see every class I am showing you how clinically you can say that science is written by our ancestors. We did not detect or describe all these things. Our senior, older physicians have found out this is the pressure sensitive tract, this is the ischemia sensitive tract. Our job is only to learn it and reproduce and see it with advanced tools that this is all true. And enjoy that and help your patient. Very good, ma, very nice. Thank you for taking a case and presenting very well. And again, giving me the pleasure of enjoying clinical neurology. Very good.